This is Dennis from the PFC Podcast. Today we're talking with Emily Johnston on the challenges you're going to have to face when doing TCCC or just initial care in the Arctic. We're talking about hemorrhage control and getting access to the patient. We're talking airway management, maintenance of that airway, lots of hypothermia management, and we managed to shoehorn a bunch of tips and tricks in between. Forearmed is forewarned. Let's get into it.
Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Emily. How are you doing today?
Doing great, Dennis. Great to see you again.
Hey, very good to see you. I think this is a very timely podcast, seeing what's going on in the world. But we're going to talk about a new CPG that was just submitted anyway, all about the Arctic. And so there was none other that I would ask about that than you.
Well, thanks, Dennis. It is definitely a strong area of interest for me, and it is pertinent these days for sure.
Yep, absolutely. So I guess I can't help but poke the bear. Why do we need an Arctic CPG when we have perfectly good cold weather CPGs?
Well, you're not the only one to ask that question. It's a great question. And this extreme cold CPG is really meant to be sort of the icing on the cake. This is not meant to replace anything. It is meant to just be looked at alongside. It's an adjunct. So these are cold weather considerations that you add on to your TCCC, that you add on to your other CPGs. It's considerations, some points that will help you operate in the extreme cold environment more easily. So not meant to replace, but meant to be used alongside the existing CPGs.
And I noticed in this initial write-up anyway, it's pretty heavy as far as TCCC focused up front. Like, I guess, what are you adding? Like, why is it so hard in the Arctic to do TCCC?
Well, there are a few things that are more difficult. The threat of hypothermia and frostbite is constant. And even though that is, taught from the beginning, hypothermia, this is from the very beginning. You want to be thinking about hypothermia. And you also need to be thinking about how you're managing your gear, yourself and your patient while you are operating in that environment, because you have to be thinking all those things concurrently, because your casualty is obviously prone to being hypothermic in any environment, but you need to take care of yourself so you don't end up with frostbite on your hands from doing your job, or you don't end up hypothermic. And the gear is really important as well, because there are certain ways you can manage your gear or not manage your gear that will allow the gear to be useful or to be not useful. So I think the idea is thinking about all those things at the same time. That's sort of what we add into the TCCC. These are the components that you need to be thinking about at each stage of treatment, and the treatment that most of us have already been heavily trained in.
Yeah. So, just starting off with just hemorrhage control, you mentioned like cutting windows in to get tourniquets on after you've done your high and tights, and you even have recommendations as far as using the ratchet type tourniquets to avoid Velcro and things like that don't really do that great in that cold of a environment. I think it's also super timely with the things in Ukraine, where they're in the middle of winter right now, and they don't have super expensive, lofty clothing. They got whatever they can layer on top of the other things. Those tourniquets, when it's applied to thick clothing or multiple layers of clothing, and the wound itself is covered, like, I guess, how do you know you've done a decent job?
Great question. And, I have to say, part of this is a lot of this we don't know for sure, right? We haven't tested it over and over again. We haven't collected data. What we're doing is drawing on the experience of the Ukrainians, of other partner nations in cold environments, and then what we've seen and done. I have to say that some of our thicker layers, particularly not down so much, but synthetic thick insulating layers that some of our folks are using, it would be very difficult to apply a tourniquet effectively over those layers. It would be really tough to get it tight enough. As you know, just applying a tourniquet on skin, a lot of times it's not tight enough. And now you're adding a whole bunch of layers on top. And the fact is, we don't know which tourniquets could actually get tight enough over that clothing and which couldn't. So the windows, cutting specific little windows in to put tourniquets on and to do other interventions is really what we need to be working with. Obviously, in the extreme cold, the idea of trauma naked is not a good idea. So you want to go with those windows. It makes assessment of the casualty much more difficult because the insulating material can obviously soak up a lot of blood. So you have to do a very careful sweep, check your hands frequently. And then applying a tourniquet, it does make sense at times to cut an area, cut open just a slice in the insulating layer and go underneath and place the tourniquet and then check it carefully. And once again, it's going to be more difficult to check it for efficacy to see if the bleeding has stopped or not because of all the clothing. But if you're selective about where you cut, and if you know how large of a cut we need to make in order to place a tourniquet effectively, if we know those parameters, then we can do this more effectively. So in this extreme cold CPG, we talk about cutting windows to do interventions, and we don't designate how large of a window you need for a tourniquet, how large of a window you need to start an IV. And those are things that we are still learning. But what we want to do is get the word out so that people understand, what to be thinking about in terms of providing care in that extreme cold environment. And this is, like all of medicine, a work in progress. I do think applying a tourniquet, directly to the skin, if you can do that, is the most effective.
So you mentioned like this is a thing that's already done and has been done for, I'm sure, quite a while. And in the ski patrols and different units and professions that work in this environment on the daily, right? So are there like specific places that they start, or like I'm used to just going from the pant leg like straight up to the junk and filleting that pant leg open and going to work. It's probably not going to work so well.
Exactly. And, it's sort of where the injury is, but if you are thinking high and tight, which is, the best sort of initial option, having sort of designated spots where you cut, and whether you cut horizontally or vertically on the leg, that would be something to consider. And it's also based on the insulation. If you got down to have, and you've talked about this yourself, to having specific cut spots where you can cut through the insulation layer without, exploding down all over the place and maintaining that insulation layer, that would be an interesting strategy. And, that's something that you mentioned was to, have the spots, and there could be a couple spots that would be in those high and tight positions that would be marked or oversewn or something like that, where we know we can cut there and apply a initial tourniquet high and tight, and then, assess more after that. So, generally speaking, you want those windows to be as small as possible because you don't want to lose a lot of insulation or a lot of heat. But that being said, you don't want to make it so small that you can't get your hands in there and do what needs to be done. Once you have a cut in the insulation, if you do it appropriately and, you're not just tearing it wide open, but selective cuts, then closing it with something like, a red piece of tape, write TQ on it and the time. Or, a red piece of tape, write IV on it, 18G and the time. And so that would be a way that people would know, because otherwise, imagine that you'd make a selective cut, you put a tourniquet on, and then you replace the insulation so the patient doesn't get cold, and now nobody knows there's a tourniquet there. So a standard for that, and that's just something actually that's come up since the CBG was submitted. So, like I said, it's a work in progress. But what we want to do is get this out to everyone. People can use it, and then they'll have feedback, they'll have new ideas, and that's how things progress. You got to start somewhere and then continue to progress. So that's the idea of this CPG.
Yeah, no, it's perfect. I think just as professionals, as perfectionists, you make something that's like 100% correct on everything, so it stands the test of time forever, and that's not really reality. So just getting even if it's a 70% solution out is far better than waiting for the 100%.
Yeah, better is good's worst enemy, and some of these ideas will get to people where this is novel to them. They have not worked in the extreme cold, and they're like, "Oh yeah, I didn't think about that fact. I didn't think about the fact that a limb distal to a tourniquet will freeze if I don't do something about it. If it's -20, right? I didn't think about." So getting people thinking about them, and then other these points, there are people who have operated in these environments. I mean, the PJs in Alaska, the dust-off medics, and people in other places where it's extreme cold, getting some ideas out. There may be solutions out there that have been used that we don't know about. As I mentioned, I've been a professional ski patroller for a long time, and you end up doing sort of on the fly work in the field where you cut a little window of opportunity and take a look at something or check something, check a pulse, do whatever you need to do. And that's not written down anywhere. It's sort of lore that's passed from one patrol generation to the next, but it's not really written down anywhere. I would imagine that's the case too with rural ambulances in the interior in Alaska and other cultures that operate in the extreme cold. And this is kind of a net. It goes out there, provides some education, and it's also probably going to bring in a lot of information as well.
Yeah. I mean, if there's anything that people love to do is listen to a podcast and hear something that's wrong and then drop their opinion somewhere. So there's a good chance that we'll find somebody to correct or point out our mistakes, right?
Which is great. I'm wide open to that because the whole point is to figure out how to do it as effectively as possible to provide the best possible care for the casualty and protect the provider as well. So bring it.
One of the other areas that's in the CPG is talking about like airways and like just protecting your airways because the moisture, the condensation from the breath can freeze inside that ET tube, and I've thankfully never had to clear ice out of the inside of an ET tube before. I guess how do you protect that airway?
Well, there are a few ways. I mean, the airway in the cold, there are a few considerations. One is the actual devices that you use. If you try to use them when they're frozen solid, that's not going to work very well because they're designed to conform to the anatomy of the airway, right? Yeah. When they're soft, pliable. But if you try to put something in there when it's not soft and pliable, you could potentially cause significant damage, right? Sure. So that the first thing is the appropriate choice of a device and then making sure that it is appropriately warm enough to do what it's supposed to do. There's that. Then there's the condensation, which it happens remarkably fast. A few days ago, I was out teaching, and it was about, I don't know, -25 or something like that. And within a few minutes of being outside, my hair gets frosted. The front of my coat is frosted to the point where like I can't unzip the zipper because it's frosted. And so thinking about that and ways to, obviously, prevention is the best way. So if there's some way to have it warm or to have a warming device on the some kind of warming feature on the device, that would help prevent the ice from forming. But once it's formed, I mean, the only thing we really have to do right now is to apply like a ready heat, some kind of chemical heater, or to warm it in our hands, right? Or to blow on it. Like those are the things you do with your fingers. And that's the extent of the technology we have for de-icing these things, that's not very sophisticated, right?
Well, with every breath, they're going to add another layer of ice. So if you don't do something soon, it's going to be frozen solid, and then they will suffocate.
Yes. And you might not notice. Hopefully you would notice, but if you have a bunch of casualties that you're managing at the same time, you might not realize, like, why is that patient doing so poorly all of a sudden? And, as you know, from, when you're working with a ventilated patient, when things start to happen, one of the first things you do is disconnect the tube from the ventilator, just to see, like, what's going on. So that would be the first thing, would be to check the patency. There are other things you could do. You could, like, kind of have a plunger that pushes the ice out of there, or pulls the ice out of there. That would be another thing. But actually keeping that part of the patient in some kind of a warm bubble, like if you had a red heat over it while it's, I'm working, like, talking about like crike here because I'm my neck, but the mouth, whatever it is, if you actually had a ready heat, some kind of warming device over the top of it, or you had the casualty in a warmer environment, like a bubble of warmth or haven, where the air temperature is a little warmer, but it's definitely something to look for. And that's one of the places where we could use some new technology that will prevent that from happening. And we don't have it. And if somebody does have it, I'd love to hear about it.
The HME, so it's kind of designed to keep everything contained and moisturized and things like that. I would imagine that probably hinders you when it's so cold. It probably is a big sponge that'll freeze.
Yeah. Well, and part of one of the things you worry about ventilating a patient in that extreme environment is the extreme cold air hitting, like, the lungs, the bronchioles in the lungs. And so you do want to have some in the dry, cold air. So you do humidification is a good thing, and warming it up is a good thing. That's why our noses are designed the way they are, right? It's a super complex, really interesting pattern that the air has to run before it goes through your nose and, go down into your lungs. And the reason is it's humidification and warming, right? But if you're putting a tube straight down into somebody's lungs, you're bypassing all that. So humidification and warming are important. But what we need to do is figure out a way to do that without causing an ice plug. And that's something that we will, we'll work with more. We'll test that. But knowing that can happen, I think, is the most important thing. And a lot of the concepts that we have in this extreme cold CPG are just that. Like, look out for this. These are things that people may or may not think about. And so these are things to be aware of. We may not have the solution right now, but I bet if we put this out, people practice it, people look through it, we're going to have more solutions in a year or two than we have right now.
Oh, yeah, absolutely. Like, you put enough people in a really crappy spot, they're going to figure a way to make it better.
Exactly. Yeah, it's true. It's absolutely true. And I have to also give a tip of the hat. Really, Chief Petty Officer Wesley Gorman was the one that really herded the cats to bring this to fruition. So he is really the one that made all this, kept everybody responding and all that. There are a lot of authors, so I have to make sure that he gets credit for herding all these cats and gathering the information and everything. And I think going forward, it might be somebody else. He did a great job, but I bet it gets tiring to do that. So gathering information is a great, that's what we're looking to do, is provide what we know now and then gather more information and continue this moving forward.
Yeah. And another big part of the CPG, you're talking about the bubbles of warmth, and we talked about it in the last podcast, and you kind of laid it out in a little more elaborate way, kind of good, better, best kind of situation. So that was really helpful too. Sustainment wise, like nutrition, hydration, super important. One of the things in the CPG, it mentions, needing 4,500 calories plus a day just to exist. Like, logistics wise, like, that's a lot of food for these dudes, right?
How do you do that without your jaws getting tired? Is that what you're saying? Well, there are a few ways, and we know this from polar explorers and everybody else. And one is that fat has more than twice as many calories per gram, that more than twice as many than carbs or protein. So fat, if you're having you think about weight and stuff like that, fat is really important. Um, it provides a lot more bang for your buck. That being said, you don't want to just gnaw on butter the whole time you're out there, right? That doesn't sound so great. So there are a few things to think about. It's interesting because I was over in Norway last spring, and there was a Norwegian team that was out self-supported for like 100 days in a military team. And their nutritionist presented what their rations were. And it was interesting because it wasn't, I mean, I think part of it is people wanting to eat that much. And it was like, the number one thing was chocolate, potato chips, things that are palatable, things that you're going to want to eat because it's hard to eat that many calories. And in the cold, also, sometimes people sort of lose their appetite or they lose the drive to like prepare food. So a lot of their foods weren't necessarily needing to be prepared, but they were palatable things where you'd remember it. You're like, oh yeah, I got that chocolate in my pocket. I'm gonna eat that. Things that you're driven to eat. I'd spend a lot of time at altitude as well, and working with people who go to altitude, and that's there. The anorexia, the loss of appetite, is a significant burden. And so I think there are a couple things. One is if you're gonna eat a lot of calories, and this is what I tell people when I take them on climbs or I take them out on winter exercises. I'm like, this is not a weight loss trip. This is where whatever makes you happy, that's what I want you to have. You want, a bunch of Snickers bars, go for it. This is not like, we're not worried about good nutrition so much here as we're worried about like what the things are that you want to eat. So there's that. Another thing that I tell people is there needs to be no barrier to you getting the nutrition. So have a pocket that's designated as your snack pocket and have stuff in it that you do not have to unwrap or take your glove off to eat in extreme cold. So you just stuff your hand in that pocket and you pull out something that you like. I particularly like Mike and Ike's hot tamales, gummy bears. You can do nuts, some chocolate in there, but it's in this pocket and you can just pull stuff out. You don't have to unwrap it. Just put it in your mouth and chew it. That's important. And then the other thing is really, if you're working out a lot more, it's a harder physical task, then you do need more calories. But if you think about it, if you're wearing the appropriate amount of insulation and you're managing your temperature appropriately, you don't need that many more calories for thermogenesis. I wear a lot of down. I have a feathered friends down suit that I wear up high in the Himalayas. I have a huge parka and huge pants that I wear in the extreme cold environment, and I'm usually relaxed and warm inside of that environment. In fact, I never wear a hat and I often don't wear thick gloves because I keep my core super warm. So in that case, I don't actually need a whole lot more calories for thermogenesis because I am warm enough, because I'm managing my stuff and I'm not afraid to look like an Oompa Loompa. I'm like, yeah, I am got a ton of insulating gear on, and so I don't need a whole lot of extra calories. So those are sort of a few different thoughts I have on that idea of, you know, needing 4 to 5,000 calories. One, there are easier ways to get it, more fat, palatable food. That's important. And then, if you manage yourself appropriately, maybe you actually don't need that many more for thermogenesis. You still need them for physical tasks if it's more physical.
Sure. Now, I don't mean to put you on a spot, but the idea just came in my head, so I'm going to fire it. So, I'm guessing the patient is also included in this need for nutrition.
Yes, that's true. It's both the rescuer and the patient. The patient for sure. And once again, if you're managing the patient appropriately. Now, we know that trauma patients are hypothermic, even in the desert, right? Anywhere. That hypothermia kicks in rapidly. And that's not just an environmental consideration. It has to do with, there's a lot going on there. But basically, we know that trauma patients are hypothermic. So once again, they do need more calories for a variety of reasons. If you're injured, your body needs a bunch of calories to repair things, make more blood, all that stuff. And in addition to that, to address the hypothermia, if you're shivering burns a ton of calories. it produces a ton of heat. But once again, if you can manage that patient appropriately, if you can get them to the point relatively quickly where they're not hypothermic, they're not shivering, you don't want to be shivering. You want them to be using those calories to help manage the injuries that they have and to help starting to repair things, make more blood, do all the things that they need to do. So if you can aggressively manage that hypothermia, which is one of the things that we harp on over and over again here in this CPG, um, then once again, they might not need that many calories, right? A gravely injured patient, it's difficult. Nutrition is really difficult if they can't eat and drink, if they're unconscious. That's goes beyond field care, really.
Well,
But
it definitely gets way more complicated. That's for sure.
yeah, it does. But you're right. But once again, if we can manage them, provide an exogenous heat source, insulate them really well, do all and not give them, cold blood or cold IV fluids. If we can do all that correctly, that will decrease their caloric need, which is something. I mean, it's a limited resource, and so that's definitely to consider.
Yeah, having done it, like hypothermia management is freaking hard. Once they've lost that heat, it takes a lot of heat to put back into them in order to get them even close to normal.
Yeah.
So your work is cut out for you. Oh, by the way, you're still out in the freaking cold. So everything is fighting you. I guess on the nutrition side, please tell me if I'm wrong, but if they're healthy enough to tell you that they're hungry or they're thirsty, go ahead and give it to them.
Yeah, I mean, I guess it would be based on the injury pattern if they have an evisceration or something. But, it also depends on how long you have to get out. There's the medical side of it. But if it's medically appropriate to give them a nutrition, then yeah, go for it. And what's great is hot calorie rich liquids. Like some people use like hot Jello. So it's Jello that hasn't gelled yet, and that is like rocket fuel. That is just it's a ton of calories. And once again, here you're not so worried. Yeah, it would be great to give them some protein and fat and balance some macros out. But if all you can get into them is carbs, that's fine. They just need So warm liquids is a great way to provide nutrition and internal warming at the same time. Yeah.
You mentioned like DMBI earlier, frostbite, things like that. So is there any real changes to treatments of these cold weather injuries?
Well, so, there are the non-freezing cold injuries like trench foot, chilblains, those kind of things. And that's basically, there's no change. It's, how it's always been. Put on dry socks, keep your feet dry and warm, make sure they're warm at night. Like that hasn't changed. Frostbite, though, there are some changes. And there's some misconceptions that I've run into quite a bit. One of the earliest, so frostbite, when the tissue is frostbitten, it's sort of, in suspended animation, right? The ice crystals have formed in the tissue. There is definitely damage done. But the clock really starts when you thaw that tissue. And when you thaw that tissue, there's a bunch of stuff that happens that's basically reperfusion injury when the blood starts flowing back in there. And that is from thaw time. Time is tissue. And the sooner you get certain medications on board, the more tissue you will hold on to. And the timing is very important. So if you look at the protocols, it'll say ibuprofen, 600, 800 milligrams of ibuprofen every 6 hours. And that is crucial. And it's not just pain and swelling. A lot of these people, it hurts so much, they will need narcotic pain medications or ketamine. But with the ibuprofen, there's this arachidonic acid cascade that drives the reperfusion injury. And ibuprofen, the COX inhibitor in it, blocks that in a certain spot. And basically what happens is when you reperfuse this tissue, you can have vasoconstriction, so worsening blood flow, and then microemboli, little clots in there. And so one of the things that ibuprofen does is it affects platelet aggregation, and it blocks one arm of this arachidonic acid cascade. So getting that on board immediately as you're rewarming is a great idea. That is a great idea, and it's not just pain and swelling. The other one is iloprost. So this is a medication. It's a prostacyclin analog, and it was approved by the DEA in the U.S. February 14th of 2024, and it is the gold standard treatment for frostbite for grade 2 plus and above, really sort of depending on how extensive it is and all that. But it is the gold standard, and it is available in the U.S., and most people don't know about it. A lot of people don't know that it's available. And a lot of providers don't know, a lot of pharmacists don't know, or they know but they don't know how to use it. They're a little leery of using it. So I think people knowing that iloprost exists, it has been used in Canada for many years. It has been used in Nepal. I've sent people to Kathmandu from the Himalayas, and they've gotten it there. It has been used in Europe as well. So it's not like this brand new thing. And we have created the guiding community, and we have seen many people treated in Canada successfully. So it's newish, but it's worth getting the word out that iloprost is the gold standard. In the past, we were using TPA, which is, the clot buster you've heard about for like stroke and heart attack and things like that. And this is a different mechanism of action. It has fewer sort of dangerous side effects, and it produces a better outcome. You can do iloprost and TPA, but if you're going to do one or the other, iloprost is the ticket. And so I just want to make sure people realize that that's now available. It's approved by the DEA for treatment of frostbite. And I know they have it in Anchorage. I know they have it at Fort Wainwright. I know they have it at University of Utah. There are places, I would imagine they have it at Hennepin in the Twin Cities, all places where they're going to see more frostbite. I'm not sure about the East Coast, but hopefully we're trying to develop some centers of excellence for frostbite treatment, which would basically be like Utah, Minneapolis, and then someplace on the East Coast, maybe Boston or something like that, which is that, would kind of cover that northern band for the U.S. And then Alaska has it, and they are starting to use it, which is great. So I just want to make sure people realize, one, the ibuprofen is, it actually treats the disease process. And then the iloprost, so it counters that vasoconstriction and the clot formation. It vasodilates, and it inhibits platelet aggregation. So, and the sooner you get it on board, the better. We know it typically will say up to 72 hours. It's valuable, but it may well be up to 5 days. But if you get it on at hour 2, that's way better than getting it on at hour 24, which is better than hour 36, which is better than, so the earlier the better for all these. In addition, topical aloe gel, it's not just a groovy thing to do. It also blocks part of this arachidonic acid cascade. It's called the White Horse Protocol for Frostbite Treatment. It was written by Dr. Alex Poole, who's a doctor in Whitehorse, in Canada, and he has treated a ton of patients, and he developed the White Horse Protocol for treatment of frostbite. Just Google it. There's an actual order set. It tells you exactly what to do. And Dr. Alex Poole also has been available for consultations. It's unbelievable. He's so accessible and has done great work. So that's the new thing in frostbite.
All right. Sweet.
Yeah.
So this iloprost, like you mentioned, the earlier the better. So is this something that medics should figure out how to do if you're going to be working in the cold?
Dennis, that's a great question. Typically it's given, it's with an infusion pump. It is not just a one-shot deal. It's a little more complicated than that. It's 6 hours a day for 5 days in a row, because the onset is about 30 seconds, or no, I think 4 minutes, and it's eliminated from the body in like 30 minutes or something. So it has to be an infusion. It can be started. You can provide it with a drip set, dilute and provide it, so you can start treatment relatively early. And that's one of the questions. That's what we're looking at. It has been done. There's not sort of a standard protocol that's been set up. And so that's one of the things people are scratching their heads and talking about right now is, how do we get this provided to the casualty pretty far forward, because time is tissue. And we do have the potential in the Arctic to be pinned down for extended periods of time due to weather or other tactical considerations. So It is definitely possible, has been done, we know, by the Canadians and others. And so having a medic carrying it, at point of injury, perhaps not necessary there, but close, as close as possible, that would be a good thing. But once again, obviously, then this is someone who gets evacuated for 6 hours a day for 5 days.
Sure. I mean, it sounds like something that's screaming like a cheat sheet recipe and fire.
Yep, exactly. Yep, that's it.
Awesome. I don't know, when it comes to CPG anyway, or just cold weather medicine, is there anything else that either we didn't talk about the last podcast or you want to get out with this?
I think it's just really that this is an adjunct, and this is to be used in conjunction with the training that we all have. It's not redefining anything, but it is. I think it's very important that it get out so that people are considering what they need to think about in the extreme cold environment. One of the things, patient packaging, I think, is really important. It's always been important, but in the desert, it's not nearly as important as it is in the extreme cold environment. And getting it right the first time is really important because you do have body heat and you do have already heat there. So all that snow on their fleece that gets caught up inside of the Skedco or whatever it is that you've got going on, that all needs to be carefully removed right off the bat. So taking the time to remove any potential source of moisture right off the bat when you package them is important, because if you think about it, in the warmer environments, you are opening the packaging up and doing a reassessment and then closing it back up and opening it back up. Here, you're not going to do that. So you want to make sure that you're assessing everything very carefully. And, assessment under clothing is much harder, putting your hands in, checking to see if you have blood, checking very, very carefully initially, marking what you have once again, because you close up that packaging and somebody doesn't know that there's a tourniquet on that leg that needs potentially to be converted, or, that kind of thing. So I think a system, the packaging system needs to be very carefully done the first time, because you're not going to undo, redo. So I think that's an important consideration. And then making sure that it's communicated what interventions you've done, because they're not obvious. You can't see them, what the injuries are and what interventions have been done. I think that's really important. And that will be different because of the difficulty in assessing the patient. Just opening that packaging up once can make the patient, it could take hours to get that much warmth back to that patient. And then having that bubble of warmth, or the haven, the Brits call it the haven, the warm haven, I think that's important, because that's a spot where you have a tent or something, some kind of a shelter that's warmish, that you can bring the patient into and do a better assessment. That being said, it's tough because the way we warm those up is with a stove, which produces carbon monoxide, which can cause the patient to decompensate, so there are a lot of things to balance here. But I do think that patient packaging is really important.
Well, again, Emily, thank you very much for jumping on.
Right on. Thanks so much, Dennis. Appreciate it.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast. Out.